IBS has been called different things. I remember the first time I ever encountered somebody with IBS as an adult. It was years ago, before I was even in the healthcare business. And this woman told me she had spastic colitis or spastic colon. I didn't know what that was, but I did know that she was uncomfortable a lot and ran to the bathroom a lot. Nervous colitis, unstable colitis. Mucus colitis was a term that was used in 1892. Dr. Osler described IBS as a disorder of the mucorrhea and abdominal cavity with a high incidence in patients with psychopathology. And I want to make it clear, I'm going to refer to this kind of thing here. And I certainly don't want anybody to think that I'm saying IBS is all in your head. It's not, but there is a psychological aspect to it. And we started knowing about that actually in 1892. 150 years ago, an English doctor said the bowels are at one time constipated and another time lax in the same person. You know, how it is that a disease has two such different symptoms, I do not profess to explain. So, you know, there was some understanding that the disease was confusing, that the symptoms were highly variable. We've known that for a long time. So the whole point here is the disease is not new, but it's more recognized, it's more commonly diagnosed. And I think for people who actually take a deep dive into the scientific literature, it's becoming more apparent how to sort out some of what these doctors were bringing up a very long time ago about IBS. So let's talk about definitions here. IBS is a constellation of symptoms that affects many areas of the gastrointestinal tract, not just the colon. The GI tract does seem irritable to patients, and that's why it has that name. It's classified as a functional gastrointestinal / bowel disorder. Now, if you're not familiar with the term functional, what this means is that people have symptoms. They are real, all right? But lab tests, x-rays, and scopes don't find anything. There aren't any blockages or ulcers or visible abnormalities. The gastrointestinal tract looks normal in IBS patients. The good news about lab tests and imaging is that you can rule out something else. You can say, this isn't colon cancer, this isn't IBS or IBD, inflammatory bowel disease. We really are, through process of elimination, perhaps arriving at IBS. Lower abdominal pain is a hallmark symptom. The pain is usually in the lower left half of the abdomen. It's less likely to occur on the right side, but it sometimes does. Upper abdominal pain, it's more likely to be a problem with your stomach or your liver or your pancreas or gallbladder. The abdominal pain in IBS really is usually associated with bowel movements. It changes before, during, and after. If it's related to urination, menstruation, or exertion, it's not IBS. So this is some of the sorting that you do to try to figure out what's actually going on. The abdominal pain can be described as being like cramps. It can be described as a sharp or burning sensation. Some people experience that pain near the pubic bone. Others feel it near the lower rectum or even in the back. Some people have even described it as similar to labor pains. And sometimes the symptoms are more vague and people can't describe the exact location, but they just describe a lot of gastrointestinal discomfort, bathroom habits that are unpredictable and that often involve discomfort and that sort of thing. The abdominal pain does not have to be present every day. The patterns are highly variable. Like some people will say, you know, some days I'm fine and some days I'm not. Or I might have a week at a time where it goes away and then it comes back. I have good days and bad days, or good weeks and bad weeks. Again, it should be related to bowel habits, but even if you have a bowel movement every day, it can happen at random times. The patients sometimes say, I feel the most discomfort in the morning, but then it seems to go away at night. In some cases, it's constant and it never goes away. And a lot of bloating and that sort of thing can take place. But even if the pain is constant, an interesting thing happens for the IBS patient. It goes away while sleeping. And this is an important distinction. So if you have inflammatory bowel disease, let's say ulcerative colitis, the person who has IBD may wake up 3 times during the night to have a bowel movement and experience intense pain, the same type of pain that they experience during the day, all right? The IBS patient generally sleeps through the night and does not experience any of the discomfort, mild or otherwise, when they're asleep. Disordered bowel habits, which could involve constipation, diarrhea, or alternating symptoms of both. That's what the English doctor was talking about. How can it be in the same person that they have both of these things going on? The response to the symptoms varies. In other words, when people describe it to you, they describe it differently. Some people say they're in pain. Others people say what bothers them most is fecal urgency, while some people will say that never happens to me. The pattern of symptoms varies from person to person, but it becomes very consistent and specific for the individual person. And the symptoms are usually intermittent with some symptom-free periods that can last days, weeks, months, or even years. Some people, however, will have symptoms without any breaks. So there's high variability, and that's what sometimes makes this difficult to diagnose. And it also causes people through a process of elimination to determine that what they have is IBS, but that may not really be the case. So I promise this will become more clear as we go on, but I think if we don't talk about the confusion, it's very difficult to tease out. There are three patterns of altered bowel movements, which can be predominantly constipation, predominantly diarrhea, or alternating both. IBS with diarrhea, the pattern usually is the first bowel movement of the day is kind of normal, and then subsequent movements become looser and they're accompanied by increasing urgency. The symptoms will temporarily resolve with a bowel movement, but they will return before the next movement. And then often when the diarrhea is finished, watery stool will follow, often including mucus. And fatigue is very common as well. If IBS involves constipation, it involves the passage of hard stools that look like pellets. Straining and incomplete evacuation are real common. The stools can be covered with mucus. What both will tell you is that bloating and abdominal distension is common to both. And there generally is gas, delayed transit of gas, and increased sensitivity to gas. Fecal urgency is common. Increased numbers of bowel movements common. More severe cramps and spasms following a meal are common. All of the above, however, are exaggerations of a normal response. So let me explain what I mean by this. And again, I want to qualify this because I don't want anybody to go off the deep end before we're finished with this here, is that nobody is going to say, I'm not saying that this is in your head, but I am going to tell you that there's a difference in the way that people experience the same thing. You probably are aware of that. All right, so most people feel the urge to have a bowel movement after at least one meal per day. It's called gastrocolic reflex. So what happens is food in the stomach stimulates receptors that send signals to the colon 30 to 45 minutes later. And essentially the message is time to clean out because more is coming soon. What happens is the signal for the IBS patient feels stronger, and it can even occur while eating. It kind of occurs in other people, but it's not as noticeable to other people. So fecal urgency results, and it sometimes happens during meals. And part of that is the anxiety over the fact that it's happening at all. At one time, the diagnosis of IBS was considered a diagnosis of exclusion, and I would say that that's still going on out there. I see it every day, but it has been cleared up a little bit by the use of what we call Rome criteria, and that's changed several times. So the current guidelines, and the reason they call it Rome is that the original guidelines were developed in Rome. During the last 3 months, the patient has experienced abdominal pain associated with two of the following: pain increased or unchanged with defecation, change in stool frequency, change in stool form or appearance. The term discomfort has been taken out because of lack of specificity. So there has been a growing recognition that there were so many different symptoms and constellations of symptoms and variations on symptoms that we were calling everyday people who had constipation, people with IBS, and what they really needed was to eat more fiber and drink water, whatever. And I'll come back to that too. But when that happened, the incidence or diagnosis of IBS dropped by about half. So discomfort is a term that's just way too subjective to have as a hard criteria for describing something. And then the patient should have one or more of these symptoms at least 25% of the time. Abnormal stool frequency, less than 3 times a week. Abnormal stool form, lumpy, hard, or loose. Abnormal stool passage, straining, urgency, or incomplete evacuation. A bloating or feeling of abdominal distension in the passage of mucus. In everyday practice, many doctors use much less stringent criteria. So this goes to the misdiagnosis that I've referred to a couple of times. So let me give you an example. A patient goes in to see a family practice doctor, an internist, maybe even a gastroenterologist, and says, I have gas and bloating, a lot of it. And I sometimes have this pain and cramping. And you know, I can be constipated for a few days and then it gets better. I'm constipated around my menstrual period. And that may be called IBS. It's not necessarily IBS. So a lot of people who just suffer from constipation or diarrhea or gastrointestinal problems like gas and bloating, the reason why they have those problems is they're eating a poor diet. They're eating dairy products. They don't have enough fiber in their diet. They're dehydrated. Remember, fiber is absorbed by water and then it puts pressure on the colon to create peristalsis, the movements that move things through, right? So if you're dehydrated, you can have a lot of these kinds of symptoms, and most people aren't dehydrated all the time. So consequently, we have a lot of people who are being told that they have IBS when there's actually something else going on. So there's more to it than just these symptoms, right? And that's why you see this variation, like it could be 20%, it could be 50%, it could be 10 or 20, you know, we'll never really figure it out as long as this misdiagnosis is going on, and it's going on every day. Patients are often misdiagnosed. We miss acid reflux, IBD, and food allergies can be a part of it. And the symptoms are vague and non-specific, and they're common to many other diseases. So I think it takes some doing to figure this out with somebody. There are no blood tests or imaging that diagnose it. That makes it harder, all right? And many times the diagnosis is delayed as a part of this. And what makes it even more complicated is that there may be periods of time for many people where it seems like it spontaneously remits for a while. And we'll talk about why that happens. So we don't need to go see a doctor, right? Here is what is not IBS. Weight loss is not indicative of IBS. Anemia, blood in the stool. Fatigue itself is not a hallmark symptom of IBS. Muscle and joint aches and pains, and fevers and night chills and jaundice. So why do I have this list here? Because a lot of people who have these things are being told that they have IBS. Misdiagnosis is very, very common. Here's a list of conditions that could explain symptoms reported by patients who think they might have IBS but really don't. Inflammatory bowel disease like Crohn's or ulcerative colitis, which often involve diarrhea. And so what somebody may be experiencing is the beginning of that, not IBS. Microscopic colitis, celiac disease, which is an autoimmune disease that involves a severe response to gluten that requires complete abstention from gluten. Food sensitivities or food allergies, legitimate ones, and that's overdiagnosed. That could perhaps be a topic for next year's conference because we could take a deep dive into that. A urologic origin of pain like kidney stones or even interstitial cystitis, which can sometimes bleed over into certain types of gastrointestinal problems too. Ovarian cysts, endometriosis, and uterine fibroids. All of those things can cause issues with bowel health and gastrointestinal health, and they are not IBS, all right? Pelvic inflammatory disease, viral gastroenteritis, cancer, pelvic floor dysfunction, diabetic neuropathy, which everybody associates with feet and hands, but it can also affect, it can cause constipation. And gastroparesis, those are not IBS, although they can cause symptoms that seem to be IBS. So between the bad diet, dehydration, and all of these things, you can see how a lot of misdiagnosis goes on and why we see this huge amount of variability. We really don't have any idea how many people have it. The people who you can tease out what's really going on, we know we know some people who are part of our client group actually have it. So if you're going to try and diagnose IBS, some guidelines include avoid all the extensive testing. Endoscopy, colonoscopy, and stool tests generally don't tell you much. The studies show, by the way, that the incidence of serious disease is the same in people with and without IBS symptoms. So you can't justify the stress and expense of extensive testing. There are no firm guidelines in which tests should be performed. And so there's some judgment involved, unless, in other words, diarrhea can be a symptom of IBS. At what point is the diarrhea so serious that you're thinking it could be inflammatory bowel disease. Well, that's a matter of judgment, because many IBS patients say, I have 4 or 5 bowel movements in the morning based on the scenario that I described earlier. And then you have other people that it goes on all day long. So there's a judgment call involved in this. The American College of Gastroenterology recognizes IBS as a condition, but says in the absence of some clear reason for alarm, the symptoms alone can be used to diagnose. The most valuable is a patient history and a symptom profile, and the patient history is maybe a little bit more broad than you might imagine. So what should be, what you might do just as a standard visit to a doctor, get a blood test, look for anemia or infection. Patients with constipation, you might look at a thyroid test, but the incidence of thyroid disease is not higher in people with IBS. Patients who have diarrhea, inflammation will tell you, measurements of inflammation like SED rate or CRP, calprotectin, these kinds of things might tell you if you're more likely to be dealing with IBD than IBS. And if somebody's been to a third world country, you might want to check for parasites. Unfortunately, we have a lot of practitioners who check a lot of people for parasites that don't really have any risk for them. But if the person has been to a third world country or in some scenario which would make parasitic infection a likelihood, you might want to check for that before you say it's IBS.